Uh, Good evening, Assalamu alaikum, everyone. We are on to module 2, which is muscle invasive and metastatic bladder cancer. And we have a tight program this evening. We will be talking about neoadjuvant chemotherapy, what is the current best evidence, and we were fortunate to have Professor Hussain to deliver this talk. This will be followed by decision-making in muscle-invasive bladder cancer by Mr. Nandwani from Nine Wells. Some aspects of pathology, and particularly the variant pathology, by Professor Zishanuddin from Pakistan, and imaging and the diagnosis and follow-up of patients with bladder cancer, muscle-invasive bladder cancer, by Dr. Basit Salam from Oman. So we know that over the past quarter of a century, since that randomized controlled trial was reported in, I think, early 2000, neoadjuvant chemotherapy has become the standard of care. The question really that Professor Hussain will be addressing is that for whom? What are the age cutoffs, creatinine, and some of the other aspects? We know that not all patient responds to chemotherapy. So who will respond? Do we know? And what is the future in predicting response? We know that the standard of care is cisplatin-based chemotherapy with gemcitabine and cisplatin. What about those patients who are not eligible for cisplatin? Is there a role of immuno-oncology in that aspect? And to discuss all this, we're very fortunate and honored to have Professor Hussain, a world-known figure in Uro-Oncology and some of the other aspects of medical oncology. He is a professor of medical oncology in Sheffield Teaching Hospitals in UK. So, and we are very grateful that he could come over tonight from his very busy schedule. Now, the second part of the presentation is about decision-making in bladder cancer. And this is an important talk, and it's important that we make the right decisions. And Mr. Nandwani is going to talk about which NMI urothelial cancer are for upfront cystectomy. We know that all muscle-invasive bladder cancer definitive treatment is cystectomy. Who should undergo the neoadjuvant, part of which will also be covered in Nandwani's talk. Response assessment following neoadjuvant chemotherapy, the emerging role of VIRAD and the ctDNA. Is radical TUR the way to go still for trimodality treatment, and what should be the extent of lymphadenectomy? So to discuss all this, and I'm sure much more, Mr. G.M. Nandwani, consultant urological surgeon at the famous Nine Wells Hospital in Dundee, Scotland. The third presentation is extremely important. Like imaging, pathology is a cornerstone in the management of urothelial cancer. We know that muscle-invasive bladder cancer is always high grade. So it's very clear that we should not ever entertain a low-grade muscle-invasive bladder cancer. What pathologists expect from urologists who are performing TURBT and radical cystectomy, and what the urologists expect from pathologists to report on a TURBT and a radical cystectomy specimen. So these are the aspects that Mr. Professor Zishanuddin is going to take up in his talk. We know that bladder cancer is not a single entity, and we have small cell neuroendocrine variant, which is a very aggressive cancer. We know that squamous cell carcinoma, pure adenocarcinomas are there, the urachal and the non-urachal subtypes, and micropapillary, which is a very aggressive variant of bladder cancer. To all discuss this, Professor Zishanuddin, the GU pathologist at Aga Khan Hospital in Karachi, will be taking up these aspects. Radiology, as is for any cancer, it's extremely important. in decision-making in bladder cancer. The role of pre-TUR BT imaging, ultrasound is the standard. We know that 3 Tesla MRI and VIRAD scanning is the current standard, and although there much needs to be done, but hopefully it will be the way to distinguish between T1 and T2 cancers. Staging, CT, MRI, response to neoadjuvant treatment. We know that MRI scan is better than CT scan. What about metastatic disease? So to take up all this and to talk about what are the goals and which imaging modality should be used to achieve those goals, Mr. Dr. Basit Salam, an ex-AKU alumnus and a consultant radiologist at AKU, and now a consultant radiologist at Sultan Qaboos University, Muscat, Oman. So we've got a very exciting 1.5 hours, and I'm sure that you will make the most of it. It will be a great learning experience. Without any further ado, I will unshare my screen. And Professor Hussain, the screen is all yours. Thank you very much for being here tonight.
Thank you very much, Hamad. Thank you very much for organizing this course. I'm extremely delighted to be here with you all. And what we will try to do over the next 25-30 minutes is really go through some of the evidence, some of the challenges, and the opportunities that are there as well. I think working, and again, this sort of a platform that Hamad and the colleagues have really managed to develop just throws a huge amount of opportunities for our trainees as well to consider trials, and our faculty as well to consider trials coming out from Pakistan in terms of perioperative setting, because it's a really huge opportunity in terms of perioperative settings that we have. So, right. Okay, so these are my disclosures. Right. So I think in terms of neoadjuvant chemotherapy, we know there is evidence, and that evidence is there for 20 years, really. We have got evidence that MVAC chemotherapy improved survival, basically pre-cystectomy. If you give neoadjuvant chemotherapy, there is a 5-year overall survival, 57% versus 43%, and the PATCR was 38% versus 15%. But the first data that came out was looking at 77 months versus 44 months, and that was quite significant. And since then, this has been used, but that was a surgical series. In the MRC neoadjuvant trial, there was both cystectomy series and radiotherapy. Organ preservation series was there as well. And in both settings, what was very clear was that there is survival benefit for these patients. And there was a consistent 6% survival benefit that was seen at 3 years, 5 years, and 10 years. The trial was designed looking at 10% survival benefit. That was the aim of this study. But again, I think in a patient population with bladder cancer, where there are other competing risk of mortalities as well, I think it was important to accept that 6%, embrace that 6% survival benefit and move forward. Remember how breast cancer has moved forward with adjuvant benefits of 3 and 4%. They've really moved the field forward by accepting that and that. So small steps are important. And I think in bladder cancer, as you will all be aware of, even in metastatic bladder cancer, we are making big headways. So in perioperative settings, it's important to try and get the best treatment option and improve the cure rates in that setting as well. So basically, based on that, you can see a 10-year survival of 30% versus 36% in favor of chemotherapy. Hazard ratio was 0.84. So, and I think it is important when we look at the hazard ratio, that does give you a better assessment of the impact of the treatment rather than just looking at median survival and figures like that. Because I think overall absolute benefits of 16%, I think was something worth moving forward to. And many centers globally use neoadjuvant chemotherapy quite commonly. That's the standard of care treatment now. Yes, you have to choose and select patient. You have to think, as Hamad very rightly said, one has to look at renal functions, for example, their fitness, and in terms of, if there is a hydronephrosis, we might need that correcting so that when you give cisplatin-based chemotherapy, you're not causing further impact. So when the patient is back to the surgeons, we do want that the patient is well and fit to have surgery. Remember, surgery or organ preservation, concurrent chemoradiotherapy is the curative treatment option. What we are adding on with neoadjuvant chemotherapy or adjuvant treatment is an additional survival benefit. So it's important that the patient's primary treatment is not affected. And that is important when you are thinking of your patient in front of you, but also when you're thinking of clinical trial designs and things like that. Further to that, further trials have been done to try and improve on the outcome. Abacus, done by Tom Powles, looked at atezolizumab in muscle-invasive bladder cancer, single-arm phase 2 study, which used 2 cycles of neoadjuvant atezolizumab before cystectomy. 95 patients from 21 sites, PAT-CR was 31%. But what was key here was that stromal factors were like TGF-beta, transforming growth factor beta, and fibroblast activation were linked to resistance. The reason to bring it today in this meeting was to really show that actually these window of opportunity trial brings huge opportunities there, where you can understand the microenvironment changes and the mechanisms of disease sort of resistance as well. Pure-01 by Andrea Nacki used pembrolizumab in a similar setting and found the PAT-CR rate of 42% and PDL positive and high tumor mutational burden improved response. NeoBlade is a trial that we did nationally. It was a big trial, which I was the chief investigator, and that added nintedanib, which is a FGF inhibitor, fibroblast growth factor inhibitor with VEGF inhibition as well. And the rationale was that the change in microenvironment, knowing that FGF drives bladder cancer and angiogenesis always plays a role in progression of bladder cancer, the hypothesis was that by using that drug versus placebo, one is that we'll find out that actually does multikinase inhibitor, does triplet works, does it only add toxicity or does it add to some benefits as well? NeoBlade, as I mentioned, was a randomized phase 2 trial, which looked at the primary endpoint was pathological complete response, which was negative. And I think that is important to understand that the PAT-CR rate was not different by adding this additional nintedanib versus placebo in the cisplatin-based chemotherapy regimen. What was interesting was that secondary outcome, progression-free survival, 61% in placebo and 82% that has 0.53. And overall survival, 2 years, 69% versus 89%. So there was definitely something going on interesting, which was basically adding on changes in the outcomes in those sort of settings. Then we have got immune checkpoint inhibitors, which has literally transformed the outcomes in bladder cancer. And immune checkpoint inhibitors works on multiple pathways, looking at trafficking of T cells to tumors, starting with release of cancer cell antigens and cancer antigen presentation. And priming and activation are quite important because that is quite often the rationale and theory behind, do we use it with chemotherapy or do we use it after chemotherapy, when will you see most priming and activation in this sort of things. But then trafficking of T cells to tumors, infiltration of T cells into tumors, recognition of cancer cells by T cells, and killing of cancer cells. These are all important factors that lead to the outcome and changes in this sort of a setting. There are a number of perioperative ongoing trials to try and answer that question, looking at additional immune checkpoint inhibitors into chemotherapy skeleton. We'll talk about Niagara trial as well after a few slides. But that one I just wanted to show you in terms of the Abacus 2, for example, looking at the 74 patients who had treatment, 67 had cystectomy, 7 did not have cystectomy. One of the key factors when you're looking at neoadjuvant treatment is to see that actually your radical curative treatment option is not affected. And those who did not undergo cystectomy, 1 refused cystectomy, 3 had clinical deterioration, 1 had death, pneumonia, MI, and 1 received chemotherapy instead, included in primary efficacy endpoint. So these are important things when we are looking at these sort of clinical trials in terms of that was from Tom's presentation about Abacus. And again, immune infiltration and the complete response post-treatment, we found there was, if there were PDL positive tumor, there was better response. But again, PDL is not a good marker. But again, doing these translational studies doing these window of opportunity trials gives you that option of giving these drugs. And when you take the bladder out, you can really understand the biology of and mechanism of action of disease resistance. And again, here you can see foam cell macrophages and things, which was leading to resistance. So key thing was that it was safe. Pathological complete response occurred in 29% of patients. Progression of disease appeared infrequent, and sequential biomarker analysis showed PD-L1 and CD8 expression with atezolizumab. So these results were promising in the area of unmet need, but more long-term was required. Andrea Naki's Puro-1 trial, which you have seen, there's a lot of imaging sub-studies that have come out from that as well. But it was to show that actually with variant histology as well, you may get some benefits. Again, there were patients with variant histology components, which was 34 in number, but there were patients with predominant variant histology components as well, which was 19. And again, it is important because these patients do present to us and we don't know how do we manage. Do we go straight to cystectomy? Do we offer them neoadjuvant treatment followed by cystectomy, or treat multimodality treatment with organ preservation is an option? So quite often the fitter and sort of younger patients will go for cystectomy. If it's a small cell type neuroendocrine, you will give neoadjuvant chemotherapy treatment. If it's squamous cell or sarcomatoid, perhaps they will go straight to cystectomy. With plasmacytoid variant, there's always a question mark. They don't do very well in any case, and their outcome is very poor. So again, that's sort of a reason why we should be doing clinical trials in variant histologies as well. And the reason, again, to say it all is because I think you will have that opportunity in Pakistan with the number of patients that you have, that if you develop something nationally, you can run some of those studies to see whether we should be offering in those variant histologies different treatment options as well. And I think, as you can see, that in terms of response rates, if there is a predominant variant histology, the response rates are much lower than if there's a non-predominant variant histology, which again tells that perhaps immune checkpoint inhibitor like pembrolizumab does not impact that much in this sort of a setting. In terms of the subtypes, when you look at variant histologies, what we learned from Abacus-2, a trial that we presented at ESMO, was that there is a change in variant histology. So there is a need for a dedicated pathology service, which basically reports those. And within those uropathologists, you have basically further subspecialty and expertise who will be more looking towards those variant histologies as well, and having more like a national, those are sort of things that we really need to try and develop as we move improve the outcomes in these perioperative settings as well. Abacus-2 showed that there was some response in sarcomatoid, but again, numbers are small to gain anything more. But it did show that actually in a window of opportunity trial, you can do it in variant histologies as well. Adjuvant treatment, again, is important. And again, I will just run through some of those adjuvant data, which is their CheckMate 274, on the basis of which adjuvant nivolumab is available and is used. In UK, we were given it only for PDL positive patient population based on hazard ratio was 0.55 for PDL positive patients, while hazard ratio was 0.70 for all patients. So overall, it was a positive trial, but nice to reduce the cost implications, only gave it to PDL positive patient, which is almost 40% of those patients. As I said, adjuvant treatment, if you look at intention to treat analysis, it's doubling of progression-free survival, disease-free survival, 10.9 months in placebo versus 21 months. Similarly, in PDL1 positive population, it was 10.8 months, and the hazard ratio is 0.53 versus 0.70. So definitely there is more response there, but PDL1 is quite a, it's not a biomarker that we can really trust, because we have seen different results with depending on how you are scoring that as well. There are a lot of factors which can have an impact around that. CheckMate 274 with further long-term surveillance and follow-up again showed continued benefit, and it reduced the risk of death by 56%. So hazard ratio of 0.44. So risk of recurrence or death was reduced. So with long-term responses, you could see that recurrence rate again continued to improve. And again, this is with tumor PDL1 greater than 1%, which was the NICE recommended us to. So we cannot use it for PDL1 negative patients, but we can use it for PDL positive patients. And again, treatment-related adverse events in terms of there were no new safety signals. Overall, it was quite safe. So immune checkpoint inhibitor in adjuvant setting was deemed quite safe and is available as standard of care in UK for PDL positive population. In many parts of the world, it is available for all patients. Quality of life was well maintained because remember, these are patients who have been cured of their bladder cancer very likely, but there is a risk of disease coming back, which we talked about, and therefore quality of life is really important. So any studies or anything you do, always remember the patient is at the forefront of what we are doing. And looking at the toxicities and benefits around, it is important to look at quality of life as well. As clinician, our weightage is a lot on overall survival. But a similar survey which was sent to patients, their weightage was a lot more on quality of life. IMvigor010 is important to talk about because it's a negative trial. It's another immune checkpoint inhibitor, atezolizumab, which was used. But the difference is that there was no placebo, but it was an observation arm. And the intention, if you look at that, it was 16.6 months versus 19.4 months. So one thing interesting is that the observation arm did quite well in this arm, in this trial, IMvigor010. The experimental arm, 19.4 months, is not very different to what we saw with the nivolumab arm. So it's those differences are important to look at. And for trainees, one advice I will give you today, if one take home, you can take it from is that always look at the full paper. Don't just look at the abstract, because what you should be doing is dissecting the data, looking at the differences in those three trials, why one is positive, why one is negative. And again, there was no overall survival benefit as well with further follow-up. There are differences between IMvigor010 and Checkmate. And again, one very important is placebo versus observation. So another one is that you look at the number of upper tract tumors were more atezolizumab than what we saw in the Checkmate. So again, upper tract tumors do give poorer outcome, and that can have a worse outcome as well. In many metastatic disease setting, we have seen as well, that increased upper tract tumor percentage does have an outcome differences. What you do is that negative trials are as important positive trial. You go back to those trials and look at the data. There was some data on basically circulating ctDNA, circulating tumor DNA already in IMvigor010 that was already part of the study to look at those patients retrospectively. So that data was available to look at. So once, this is where translational work going back from bench to bedside and then back from bedside to benchside is really important. That's a really classic example of that actually within the trial, although overall the trial was negative, and overall when we look at the two group of patients where this is where basically the biomarker evaluable patient population and ITT, there's no difference. So patient groups are similar between them, no difference. But if they are biomarker positive, ctDNA negative, there's no difference. But if they are ctDNA positive, the hazard ratio is 0.58 for disease-free survival, and for overall survival, hazard ratio is 0.59, significant. But again, it's a retrospective data. It generates hypothesis to try and test it in a clinical trial. But I think the reason to mention it, because you'll be hearing more about ctDNA in coming years, because this is likely to spare patients who do not need adjuvant treatment, and this is likely to escalate and treat them who need adjuvant treatment. So that is something that is likely to be coming up more, and IMvigor011 study has now completed its recruitment internationally, and you'll be hearing more about that. And that trial literally just did exactly the same. If the patient is ctDNA negative and the scan is negative, there's no treatment. If the scan becomes positive, then they're out of the trial because they've progressed. But if they're ctDNA positive and the scan is negative, they're randomized between atezolizumab versus placebo. So that is really interesting and exciting trial design, which will answer that can we select a subgroup of patients who actually need adjuvant treatment rather than giving it to all patients. Phase 3 immune checkpoint inhibitors, the number of trials we talked about Checkmate, Invigor, but Ambassador trial using pembrolizumab is another trial which Andrea Paulo presented. And again, that is a positive trial as well, showing disease-free survival improved in the experimental arm using pembrolizumab. So I'm not sure which drug you have available in adjuvant setting in Pakistan, but again, based on the trial data, adjuvant immune checkpoint inhibitor will be recommended in those sort of settings as well, based on those data. EU guidelines do mention about adjuvant platinum-based chemotherapy for high-risk patients without neoadjuvant treatment, but those who have neoadjuvant treatment and still have persistent high-risk muscle-invasive disease, or those who have not received neoadjuvant chemotherapy but has high-risk disease, that is T3, T4 plus, T3 plus, or node-positive disease, it is a recommendation to offer them adjuvant nivolumab. Things keep changing, and this is really exciting to see that actually we've got now perioperative durvalumab that has come through with neoadjuvant chemotherapy. That was presented recently, and the paper was published. What is really important is that event-free survival in intention to treat patient population was significantly favoring the use of neoadjuvant durvalumab in combination with chemotherapy versus chemotherapy alone. And overall survival as well was significantly better, has a ratio of 0.75. So these are really exciting figures. Toxicity-wise, there was no new safety signals that was seen. Patients across the different subpopulation and subgroups, you are seeing consistent benefit in the use of neoadjuvant perioperative durvalumab with chemotherapy followed by adjuvant durvalumab. So this is going through NICE as well. This has gone through and has been approved by many regulatory bodies as well. I think in terms of the perioperative disease setting, what I wanted to mention is that that brings huge opportunities in terms of, especially in cases when you're doing cystectomy, taking the bladder out. It provides, window of opportunity studies are important. It generates hypotheses, generate data that may help in moving treatment forward. And again, having a multidisciplinary team is key. And I think you have a setup of this multidisciplinary team, as is very evident from today's meeting. So I think it is something for you to look at. And that's why I wanted to just mention a few slides on that we are doing a trial called INVEST, where we give passive installation of intravesical atezolizumab or intratumoral injection of atezolizumab. This is done by myself and Jim Cato in Sheffield as a single center. We got a big grant from Roche to do the clinical trial. We got 1.5 million pounds and another £1 million for translational sub-study as well. So in terms of patient, will have single injection of passive instillation followed by cystectomy, or multiple injection once the single dose has been done, which we have completed now. We gave 600 milligram and then 1200 milligram, both passive instillation and intratumoral injection. Both were found to be safe, and we have carried that on. Further to that, we have got this as classic in sort of a treatment, the way we do it, passive instillation and direct injection. It was found to be safe, and we have now moved into multiple doses of these injections. Major bladder wall. So the translational study looks at bladder wall penetration of atezolizumab by imaging, mass spectrometry, relates gene expression signatures, mutational profiles, looking at the microenvironment, quantifying changes in the tumor immune microenvironment, and effect of intravesical atezolizumab on circulating tumor DNA dynamics as well. Another trial, we've got funding, which is a big international trial with UK, Spain, Italy, and France, which I'm co-leading with my colleague in Spain, Guillermo, in Italy, Andrea Necchi, and France, Johan Laureate, which is using adafitinib or adafitinib plus sertralimab in patients who are biomarker positive. So this is for FGFR positive patients who are being penciled in for cystectomy, and we are using this window of opportunity treatment. So these are the patients who are cisplatin ineligible and going straight to cystectomy. Similarly, there are other trials that are going on, which is based on subtyping of bladder tumor. We are looking at different tumor types that are available in terms of the subtyping of bladder tumor. And we are basically looking at different subtypes and seeing that actually that will make a difference in choosing and selecting patients. That is where GUSTO trial comes in, which will allow us to look at subtyping of bladder tumor. And based on that, we will be looking at the outcome in these patients. In terms of within a randomized clinical trial setting. So this is using basically looking at microdissection and then looking at the gene chip, looking at the biomarker, looking at the subtyping of the bladder tumor. And based on that, we between chemotherapy plus immune checkpoint inhibitors, which is durvalumab and tremelimumab, or gemcitabine cisplatin chemotherapy on its own. See, a group of patients will have gemcitabine plus platinum versus patients who will not undergo any neoadjuvant chemo and will go straight to cystectomy followed by standard of care treatment. So that is how this is going on. Just to first stage is recruitment to see whether we can do the study. Then target is to genotype within 14 days. So there's no delay in the use of sort of we're not delaying the start of neoadjuvant chemotherapy, looking at expansion and genotype distribution, and stage 3 will be completion and analysis. But most of that work is only possible with a strong sort of a team working together in getting those benefits. But overall, perioperative treatment will continue to change the outcome. I think we will be using more of these immune checkpoint inhibitors based on Niagara trial. So standard of care is very likely to move to chemotherapy plus durvalumab, followed by adjuvant durvalumab in neoadjuvant setting. Those patients where you cannot give neoadjuvant chemo for some reasons, they can still have adjuvant nivolumab or pembrolizumab once that is funded as well. A lot will depend on the funding availability and access of the drugs and treatments. But I think the reason to throw on some of those additional sort of a research avenues was to really basically throw it in the open that those opportunities are available in Pakistan because of the number of patients you have, and having some funding and some grants and some will to do that sort of work will really bring huge dividends, because we want to see what is this, for example, subtyping of patients, Pakistani or Asian patient population compared to a lot of data that I've talked about subtyping of bladder tumor is based on Caucasian patient population. A lot of that work has only been possible with the big GU oncology community working together. Urologist, oncologist, pathologist, and multidisciplinary team is key to make those things happen. We have a joint Uro-Oncology system where we have a clinic where Jim Gatto is doing a clinic, and I've got a medical oncology clinic going on. And together, our patients flow between the two clinics very seamlessly, which makes a big difference in both clinical trial recruitment plus having discussions over a cup of tea while we are seeing patients in between. We can discuss those cases and talk about those as well. So I think that was the key message I wanted to give, that neoadjuvant chemotherapy is the standard of care and should be used. It does improve outcome and improve survival. And the survival benefit we see is basically in patients who are well selected. Again, you need to be very careful about those patients who are being selected and who you feel are fit for cystectomy, as long as their renal functions allow and they are otherwise generally well and fit. One should consider neoadjuvant chemotherapy treatment in this setting. So on that note, I will stop here. And again, many thanks for the invite here. Really delighted to be with you all. Very happy to take questions if that is how I leave it for Hamad. Pass it back to Hamad.
Thank you very much, Professor Sen. It's very comprehensively covered, and it's really exciting to see what is coming up. And hopefully in the next couple of years, we will have answer to some of those questions that we have at the moment. Currently, neoadjuvant chemotherapy is at least administered to 1/3 of our patients. You know that the spectrum of disease is slightly different, with significant proportion presenting with obstructive uropathy and so on, and decreased renal function. And that's why neoadjuvant is not that commonly employed. So my question is, and one of the questions raised by the audience is about disease progression midway between neoadjuvant chemo. So 2 cycles and you do imaging and you find that there isn't a progression. So what's the strategy at that point?
Yeah, so it will all depend on what is the progression. If it's a local progression with the tumor still remains organ confined, I think I will be going for radical curative treatment. They've proven that they are actually insensitive to chemotherapy or resistant to chemotherapy treatment. So they should definitely be, we usually do a scan after 3 cycles. We give a maximum 4 cycles of neoadjuvant chemo. And based on the 3rd cycle scan, I let my urology team know that this patient's coming for cystectomy. Although we book cystectomy before cycle 1, when I'm giving cycle 1, I give a predicted date for surgery to my urology colleagues. So if 2 cycles, if there's a metastatic disease, then unfortunately patient has developed metastatic disease and will not be going for radical curative treatment. The only thing I will say is that my always rationale, I feel that, this is a patient whose clone of cells are such where they are resistant to chemotherapy. They are unlikely to be completely cured by surgery as well. Very likely we do see some of these patients who may have surgery and will come back in 3 months or 6 months with metastatic disease. So there are two ways of looking at it. One way to look at it is that neoadjuvant chemotherapy has failed this patient and this patient has become metastatic. So a curative is no more on curative pathway. But another way to look at it, and sometimes, again, it's a debate we should have at points, whether we have helped, we have basically saved a patient from having a big surgery because this patient had micrometastatic disease sitting already. So when we give neoadjuvant chemotherapy, the additional 6% cure rate is there, which we have got data, and hopefully with Niagara and others, we'll see it further coming up. With Gusto, we will start subtyping, and based on that, we'll select patients. So I'm expecting that in coming years, in 5 years, you will see that the cure rate will continue to increase. So this patient who progresses after 2 or 3 cycles of chemotherapy, as long as the disease is confined within the bladder, I will stop chemotherapy, contact you directly to say, can we have surgery as soon as possible? Once the patient is recovered from chemotherapy-related side effect, which is usually 3 to 4 weeks from the last cycle of chemotherapy, that's the date I give them for surgery, 4 weeks from last cycle of treatment. But if they have become metastatic disease, then patient will be going to second-line immune checkpoint inhibitors.
What's your current imaging of choice following neoadjuvant chemo, considering that there is no evidence of disease outside the bladder?
Yeah, we usually do still CT TAP, CT chest abdo-pelvis. And again, we do pick about 20-22% thromboembolic events, which is otherwise will be missed. So we often see that actually with a better slicing now, 2 millimeter slices, we are seeing more thromboembolic events. We found in NeoBlade trial, we have done a retrospective data audit and we see 22-23%. And we're trying to run a trial of oral anticoagulants for muscle invasive bladder cancer, cisplatinum-based chemotherapy patients. But the modality we use is CT TAP, chest abdo-pelvis. Sometimes prefer to have MRI, so they know, especially in a T4 or T3, T4 disease, to see what is there. We do MRI where it will help to plan the surgery. But in general, standard of care, a CT chest abdo-pelvis pre-starting chemotherapy to make sure there's no metastatic disease. And after the 3rd cycle, we do a CT cap as well. And after 4th cycle, they go for cystectomy. In some cases, the reason I do after CT scan after 3, in some cases, patients will be quite having toxicity with chemotherapy, fatigue and things, and I may stop after 3 cycles.
Thanks. This one last question. I know that you have engagements. It's about patient selection. We know that not everyone is going to respond. What do you see in coming future molecular markers, genetic markers to better select your patient for neoadjuvant chemo than what we are doing at the moment?
I agree, Atam. I completely agree, Hamad. This is exactly what will happen in 5 years. And again, hopefully there are many trainees here as well who will be the future driving this field forward. And I want them to really know about that, because subtyping of bladder tumor will become more as a norm. The cost will come down. So we are over-treating patients. Similarly, we are under-treating some patients. And I think what will be key is that by understanding the subtyping, you will start to improve the outcome. We are seeing metastatic bladder cancer patients with me 4 years and 5 years down the line who ask me the question that I gave them 12 months and they are with us 5 years. Have I been cured? Similarly, neoadjuvant setting, you are sitting at that cusp where by using these new technologies, as you very rightly mentioned, by using molecular markers, PDL1 we know is not a marker, so I don't expect PDL1 to make any change. But subtyping of bladder tumor or a combination of markers, we saw PDL1 with CD8 infiltration plus TMB was a good marker to look at as a combination. But subtyping of bladder tumor, you'll find a group of patients who actually do not need chemotherapy at all. So in our trial Gusto, we have a subset of patients who are going straight to cystectomy. Based on subtyping, they're randomized between chemo versus straight to surgery. Similarly, based on subtyping, a group of patients are randomized between chemotherapy, gemcitabine plus cisplatinum versus gemcitabine plus cisplatinum plus durvalumab plus tremelimumab. We'll see what the trial results show, but I think it's really exciting, and I think this is how field will move forward. But again, because you do a number of cystectomies are done in Pakistan, and you lead a big center, Ahmad, with Khan University, it's really important to try and learn more from those patients where the bladder comes out, to see what is driving resistance, what is driving metastatic disease and disease progression as well. So huge opportunities ahead. And from my point of view, on my behalf, I can say I'm really happy to work with you all and to try help and develop anything that I can help and support you and other colleagues.
Thank you very much, Mr. Hussain. It was a wonderful talk, comprehensively covered everything. And I know that you have other engagements, so please feel free. You have addressed all the questions that we have. So please feel free to exit after this presentation is over. Thank you very much.
Thank you.
We now move on to the second part of today's meeting. It is about decision-making in muscle-invasive bladder cancer. And to talk about this, we have Ghulam Mustafa Nandmani, consultant urologist at Nine Wells Hospital. Mustafa, you can share your slides.
Okay, so first of all, you guys can hear me? Is that okay? Yeah, that's fine.
Yeah.
So I'll start sharing. Okay. Just sorry, just a second.
Mustafa, you see the green arrow at the middle of the year?
Yeah. Are you guys okay to see my slides? Yeah.
Yes, we can see your slides now. You can go on to the presentation mode.
Okay. So, Assalamu alaikum to all. So, I think the decision making in muscle invasive bladder cancer, I think initially I thought that, okay, yes, decision making, what to make. So I think I have planned the way what I do the decision making because it's quite different from one person to one person, but we can have something like a logical approach. What will be the decision making? So first of all, I think what in the muscle invasive bladder cancer, what we are actually aiming to treat is what will be our oncological outcomes, what we'll have in our functional outcomes, and if there are any symptoms, what improvement we need to get in the symptoms, and what would be the quality of life of the patient after we have treated it. So in oncological outcomes, first of all, we need to find, can we cure the disease? Is this completely excisable or treated either with the surgery or with the radiotherapy or by any of the means? Then it comes like the neoadjuvant or adjuvant. So I think Professor Sen has talked about neoadjuvant evidence, so that was a good evidence. So, but that's like initial part, whether you can cure. If you can't cure, if it's a palliative intent, so what can you do to manage differently? Like it's only the control we can provide, or we do something to manage some of the symptoms or whatever the needs are. That's the surgery, radiotherapy, or chemotherapy. So these are the three options. If we say the functional outcome, obviously there's one aspect was the treatment of the cancer itself. And then the functional outcomes wise, either where the functional outcome means mainly the urinary diversion. So whether they want the continent or incontinent divergence, most likely these are the ileal conduits and orthotopic bladders. I'm not going to talk in detail because there will be separate talks coming up, but this is one of the aspects which we need to consider. Renal functions, some patients which have more like a comorbidities, the renal functions are not great. So we need to see that what will be the decline in future. That aspect I'll cover later in the talk. Bowel management, there will be some alterations in the bowel functions, but we'll need to see that how much bowel function will alter. Sexual functions, I feel that all men will have an ED It's not like the prostate cancer. So the surgery is a more mutilating surgery. And then the longer outcomes, which are related to surgery itself, is an incisional or parastomal hernia, which are the late sequelae that we'll see. So improvement in the symptoms is the lower urinary tract symptoms, which most of the patients have the LUTs, which are bothering us, like the going frequently, like an overactive bladder symptoms, and with hesitancy and partial retention, followed by the hematuria, which is more common. Around about 60–70% people have these type of the symptoms. In addition, presentations with obstructive uropathy, which may be an acute or the background of the acute and on a chronic background. Edema and pelvic pain. So these are some advanced symptoms, which we are not going to talk here. And what's the actual available options to us if we are going to treat this bladder cancer, which is the muscle invasive, is a cystoprostectomy, our anterior pelvic clearance, and female genital organ preservation, radical cystectomy. So these are the main, you can select type of the options available. Radical radiotherapy with and radiation to lymph nodes. Neoadjuvant chemotherapy, we have talked about, we have seen that what's the survival advantage. The other things are adjuvant bladder preservation approaches and the partial cystectomy in the very, very selected group of patients. If we see that what are, you can select in the cure, we can provide the gold standard for the curative type of the operation for T2 to 4A and N1-2 is open the cystectomy, which can be performed by the open, lap, and robotic. However, remember one thing, if you delay the cystectomy, the outcomes are not great. The study says that 3 months, but sometimes people get confused that 3 months from the date of diagnosis. No, that's a presentation. From the time of presentation, that time should be counted, not from the date of TURBT. That's what my belief is. And this is from one of the other, it's like papers from BJUI. If we say the radical cystoprostectomy, okay, the male patient, or again, I'm not going to talk into much detail, but this is an option. Why we do the prostatectomy at the same time in the cystectomy? There is a 20% chance there is associated prostate cancer. Most likely it's not very aggressive, but that's one of the thought. Sexual preservation, yes, if there is no tumor in the prostate or prostatic urethra and bladder neck, these patients can be considered for something like a prostate sparing or capsule sparing surgeries, but I have not much experience of it. It's only theoretical, and I haven't seen any of these in my region offer these type of surgeries for the male patients. Anterior pelvic clearance, that's for the females, where the total uretrectomy, anterior vaginal wall, and the uterus, ovaries, and the distal ureters are taken away, which is the more standard form. However, there is a thought of the organ preservation. But one thing is that what's the risk of the female genital tract cancer, which is low with associated femur, but not in the long run, we cannot predict. Thought of organ preservation and the ovarian preservation, that is said that in the premenopausal, the ovary preservation should be considered. However, if you see that there are cancer like Lynch syndrome, BRCA mutations, or previous ovarian, the breast cancer problems, then they are at a higher risk of ovarian cancer. So then the preservation becomes challenging. So preferably not to offer. Uterus preservation, if we preserve the uterus, obviously it will prevent the bulb coming into the same spot, and it will give support to the neobladders. These are the thoughts, but again, it depends from person to person. You want to, it's like offer it, particularly in the elderly women. If you try to preserve these uterus, whether will they get second cancer there, and then you need to go back in again. So these are the things which you need to consider. Other factors, and which are the more important factors. So one is the stage of the disease, which we'll talk about in a moment. Type of the cancer, which is the urothelial, non-urothelial, and variant histologies. Burning questions are age, who we should be offering and who we should not be. So that's I will cover. Comorbidities, what is the impact of the other factors like comorbid factors on the cystectomy, performance status that's agreeable that those who have a good performance status should be offered for cystectomy or neoadjuvant chemotherapy. Based on the symptoms, you modify your approach. Synchronous or metachronous cancers, which are non-GU cancers, because what we are seeing nowadays, the patients are diagnosed with associated bowel cancers or female organ cancers or lung cancer. So these are the patient groups which we need to consider as well, that what we need to best for them. Oncological factors, if we say the type of histology, urothelial cell carcinoma pure, neoadjuvant and radical cystectomy is a standard that's we have learned. Variant type, it's dependable which type we are seeing. Associated squamous cell or adeno, I feel straightforward radical cystectomy. Non-urothelial cell carcinoma, apart from small cell, which is radio sensitive and chemosensitive, rest of them should have an early cystectomy. Location of the tumor, urethral tumor, the implications are these are not suitable for continent diversions. Obstructive uropathy, then the decision making is that what's the patient status and what we need, what is our aim? Should we give the neoadjuvant chemotherapy? Is it suitable for pre-procedure drainage or consider early cystectomy? So we have all because like management in all in one. Anterior tumors in the female where you can vagina and the uterus sparing surgery can be performed. Dome tumors at the dome. It's sometimes people request for the bladder preservation, so very small tumors, or particularly adenocarcinoma at the dome, which thing can be resectable, can be offered some bladder preservation by partial cystectomy. But I'm not a fan of a partial cystectomy. Stage of the disease, we'll see, like in the next slides, and as said, associated synchronous or previous cancers which are already treated. Particularly, you will see the men who already had a prostate, had the radiotherapy, and they develop bladder cancer. So this becomes challenging when you do the cystectomy, and then particularly when you're lifting up the tumor from the rectal area. So these are the challenging aspects. Outcomes of the radical surgery, if we do that, so what is the mortality? Because it always says radical surgery is a more mutilating procedure. Yes, it is a more mutilating procedure, but if you don't do what is the outcome, most likely no survival after a few months' time. So mortality rate after radical cystectomy has been reported like 2 to 3% in first 30 days, and this is increased to 3 to 8% in 90 days due to a variety of other factors. Morbidity, if in the olden series, there were the morbidities which were not graded like Clavey and Dindo. But if you see the Clavey and Dindo overall classification which are reported, that's quite variable, 50 to 90%. And what is exactly is included in the morbidity. But one thing's sure that the significant complications which are more than or equals to Clavey and Dindo 3, these are not very huge. And if you divide exactly one by one complications, the most significant complications become less and less. Readmission rates, thus obviously these are higher, around about 25% have a readmission rate due to a variety of reasons. Secondly, and what we have found in our setup, there's you can sure people are unsure how to manage people in the community, and that's why the most of the admissions are. Long-term morbidity and depends on the type of diversion and the extent patients' comorbidities. This is some of the comparative results from the various studies. This only takes into account to the open cystectomy data, where you see that there is a overall complication rates, as I said before, but majority of these complications are of minor grade 1 to 2. Then you see the major complication rates are 3 to 5 is around about 20 to 35%. But if you see the more on the right side, if you further divide, the actual significant complications become slightly less common. And then the mortality rate is coming around 1%, and in 90 days around 1.5%, and around about 4%. In the last line, if you'll see, there's a BAUS data, which is the UK audit data. This only takes the English figures. So there, you can select their figures are minor complications are around about 66% and 33% are the major complications. So now the oncological outcomes. What we see, if you see that this is based on the final histological results, if we see that the stage is lower, there is a higher chance of recurrence-free survival. That includes all the patients. Majority of them are you can say like neoadjuvant chemotherapy. So really 70-80% are had no chemotherapy, no neoadjuvant chemotherapy. So this is from the Shariat Shokas paper 2005, J. Urol. So overall recurrence-free survival is 65 to 68% in 5 years, and in 10 years it still remains above 50%. More importantly, on the right-hand side, if you see that if the disease is T1 or less, is nearly 90% and 70% for T2. But as the disease goes T3, it's or nodes are involved, it becomes less. What are the other patients' factor? Age and life expectancy. We'll see that what life expectancy we'll be talking about. Performance status, yes, the ECG status 0 or ASA 1 to 3, whichever. You might find that there are patients have a good length of comorbidity, list of comorbidities. But actually, when you see their performance status, that's different. So that patient is totally different from whose performance status is bad. Again, the psychological status, cognitive status, and manual dexterity, these all like play a part in decision making. Chronic renal disease, bowel diseases, which are ulcerative colitis, bleeding disorders, so we will see in next slides. Who we call it the elder, where we say that, okay, I'm not going to offer the cystectomy. Is it 65 to 74, 75 to 84, greater than 80? There is no consensus definition who is the actually elder, but there is a consensus that if the patient has a good performance status, that should be given the chance. Life expectancy. What do you consider the patient should have a life expectancy of 1 year, 2 years, 3 years? There's no actual definition. Like in the prostate cancer, we say that 10-year life expectancy should be there, then they are a candidate for a definitive treatment. Here, some sort of in few studies, it says if at least if there is a 2-year life expectancy, they should be considered for radical cystectomy due to the reasons which are below. Because biology of the tumor, this is the aggressive cancers, progresses very rapidly, gives you significant symptoms if it's untreated, and then it becomes very difficult to manage, and their quality of life is affected very significantly. If not treated, death happens within 6 months or 12 months time maximum. And it's not like a peaceful death. It's always with the symptoms, and that's why there is a need that we should be operating on these patients, or at least do something to make their quality of life better. What will be the aim of surgical management in these elderly groups is the cancer control, symptoms, and prevention of upcoming problems. So that's the decision-making process. What does the data say? What's the complication profile in the elderly and in the younger patients? If you see on the mortality aspect, so 30-day mortality in the over 75 is not different. And 90 days slightly higher due to the variety of factors, because these have a Charlson comorbidity index higher, non-organ confined disease. And if you see on the right side, there is a length of stay. So there is some significant increase in the length of stay. But if you measure it, it's not a significant not you can say like a very huge difference. If you see the less than 68 to median stay was 10, and in more than 80 years of age it was 11. So it's a huge difference. I won't count it's a very huge difference. Yes, there is a difference. Early complication risk, again, if you see, there is some difference, but again, there is not much more difference. Less than 60 is 24, and more than 80, it's 30. Late complications, slightly lower in older age group as compared to the younger ones. Secondly, if you see that what were the complications which were of the higher grade or the lower grade, these are not significantly different in these age groups. So based on that, the data suggests that actual complication rates between the older and the you can say like younger patient is not significantly different. Other patients factors, the renal function, cystectomy, so the chronic kidney disease. There are many patients who you will find there is a chronic kidney disease present, which is non-obstructive. In the next slide, I'll tell you about the obstructive one. What is the decline in the chronic in the renal function in these patients if you operate? 54% will have the stable disease. The definitions what they use, the decline in the GFR was more than 20% difference. What was the median time to decrease in GFR? It's 5 years. Was there a significant difference between those where the pre-cystectomy CKD was present or the pre-cystectomy normal renal function? There was no significant difference. Need for dialysis in long run is less than 2%, so this is not a huge difference. Progression-free survival, yes, there is a slightly lower progression-free survival. The reason being is because these are the patients who have been seen more non-organ confined disease, lymph nodes positive, and lymphovascular invasion. It's not due to the actual disease. Length of stay, again, slightly higher, but by 1 or 2 days. High 90-day admission rate, obviously, these are already sicker patients. Threshold for readmissions are lower, so that's why there's a difference. Transfusion rates higher, complications are higher, but again, there is no significant difference in the types of the complication. On the right side, if you'll see the recurrence-free survival, as in the upper part where the normal and the slightly, you can say like chronic kidney disease, the recurrence-free survivals are not significantly different, but overall survival slightly less because these patients have already had a slightly lower, you can say like expected life expectancy. Other factors, those patients who have a kidney disease, the renal function abnormality due to the obstruction, patients presenting with acute obstruction, there's a need for decompression. Either you do the nephrostomy, or if you are very fast, it's preferable to do the early cystectomy. Or if the decision is that discussion with the patient, if you do diversion and improve the renal functions and then go for the neoadjuvant chemotherapy. So these are the discussions we need to make with the patients and with the oncology teams if they are happy. Method of decompression, nephrostomy is the ideal choice. I don't think that the stents do anything, and stents usually get blocked and you remain in the uncertainty. Subacute versus chronic obstruction, because sometimes you find the disease was, or the high nephrosis was already present in the few scans. Do we need to do anything for these patients before we plan anything? DMSA can be helpful to exactly see that what's the function in the affected kidney, or what's exactly the good functioning kidney. The stage of the CKD, this depends mainly on the diversion type of the method, that if there is a good kidney function or slightly less normal kidney function, they can be considered for continent or incontinent continent diversions. Need for dialysis in early period or long term, this is you can say like challenging. In my practice, I have not seen any patients who required pre-operative dialysis or they have gone into post-operative dialysis in long run even. Patient factors, the inflammatory bowel disease. One of the challenging is the ulcerative and the Crohn's disease, because these are more prone for the cancers as well. So these are patients who are not for radiotherapy. What we need to see that what is the disease status, is it active or is in a remission or is completely treated. What part of the bowel is affected, that, and what procedures the patient has it. So because these will go for the radical cystectomy and lymph node dissection anyway, this will give us what's the choice of their diversion. It's an ileal conduit when there is a large bowel is involved. Small bowels involved, colonic conduit can be done. If both parts are involved, it's challenging. Cutaneous ureterostomies are the way forward. Hematological issues in the patients, particularly where there is a bleeding disorders, radical cystectomy can be performed. Particularly, you will see, uh, that patients who are on anticoagulations, there's need for bridging of the heparin and some involvement with the hematology team, and most people, they do well. Consider minimal invasive surgery, cell salvage system, and radiotherapy. Other hematological disorders, like you'll find there's a patient who already have the lymphoma and leukemia. They are in various phases of remission or relapse, being on the chemotherapy. Should we be offering them radical surgery? It all depends on their performance status. Patients with the other heart disease and the CVA is depending on their exact severity of the disease and ECOG status. This could be the candidate for various diversion of uh, uh, methods like ileal conduit or cutaneous ureterostomy or long-term nephrostomy. Neurological patients, it depends on their manual dexterity. Preferably, the ileal conduits are fine. And one other factor in the neurological patients is some people, patients already have a fecal incontinence, consider simultaneous colostomy at the same time. Another group of patients you will finding is a transplant patients, particularly renal transplant patients, and increasingly nowadays the cardiac transplant patients who are having the cancers. Should we be treating them? Should we not be treating them? In renal transplant patients, yes, surgeries can be done, but this is challenging. This is for more expert centers. Same for the cardiac transplant. So I have no experience about the cardiac transplant. There's only one patient in my setup, which I'll see what I need to do, but that's the data I want to share. Symptoms points, obstructing and storage symptoms. Will they do better with the bladder preservation approach? Personally, I feel that at some point they will get some problem with their symptoms, so it's better to give them the radical cystectomy because that will surely prevent their lower tract symptoms. Frail patient who we think they won't withstand the major operation, it's better to have their diversion sorted out first, and they can be considered for the radiotherapy if they wish to be treated. Bowel symptoms, we have already, because like discussed about inflammatory bowel disease, like fecal incontinence and bowel fistula. So these are the depending things, which type of a surgery and how this should be done. This is some of the chart, which is our clinical management guidelines from the evaluation and decision making. Like, so if you first you state the disease, assess the fitness, whether they are fit for neoadjuvant chemotherapy and radical surgery or radiotherapy. If they're not fit, that intent becomes palliative. If they are fit, then we need to check that there is indications for early cystectomy like squamous cell and etc. These type of patients. Those who are not for early cystectomy, then have a discussion on neoadjuvant chemotherapy. Check the pros and cons, strategies, how to do the surveillance while they are on the neoadjuvant chemotherapy, and then decision making. And then the options are radical surgery. So that's how we proceed. And here I will be stopping my talk because I think there was one aspect about the lymph node extent, because I saw there was another talk in the next week or a week after. Some of my other colleagues will be covering, so that's why I have not touched that topic. But as a lymph node dissection, it should be the level 2, not less than level 2. Okay, thank you.
Thank you very much, Mustafa. Nice comprehensive talk about various oncological, functional, and other aspects. So I have tried to address some of the questions which were raised on your presentation. And maybe while Basit is talking about the imaging, you may address some of these questions. One question about the neoadjuvant. Is it if there is a patient who is cisplatin eligible, would he or she invariably goes for chemotherapy? What percentage of patients do not like to have chemotherapy in your practice and would like to have surgery upfront?
Okay. I think this is, if you will see from, you can say like patient's perspective, when we see them in the clinic, they are very scared because somehow with the bladder cancer, they are already scared. So their intention is, when can we get treated? That's their intention is, and what would be my outcome? When you discuss, you can say like the option, and then you want to refer them to your adjuvant chemotherapy. So the first question they ask, what is the advantage I will have? So obviously, you have seen there's not 5 and 7% maximum advantage in 5 years' time, not immediately. So 5 years' time survival. That's you tell. So those who are actually, you can say like eligible, how many patients you can say like choose for it. I don't have an exact data, but my recollection is I think 21% or 22% in our series. Uh, they choose for neoadjuvant chemotherapy. And what was the second part of your question?
Those who, once you have explained the benefits of neoadjuvant, would rather go for upfront cystectomy, and if needed, maybe adjuvant if there are any indicators for adjuvant. So
Yeah.
patient's preference.
Yeah. So when you discuss with them, because the adjuvant is not the standard treatment at the moment in the UK, but what our oncologists are, those who have, you can say like given an option of neoadjuvant chemotherapy and they have not chosen, and they have something like an aggressive factors, or like uh, you can say like their disease stage was T2 and now it's T3, or something like a margin positive or some lymph nodes, then they go for a discussion about adjuvant or preferably post-op chemotherapy. So that's variable from, you can say like person to person, and we don't have any exact guidelines in our hospital.
Thank you very much, Mustafa. I think it covers all aspects. We now move on to the third part of the presentation. There's a little announcement here that Dr. Zishan has some family medical emergency, and he will not be presenting tonight, but his recorded presentation will be shared to the whole group in the next few days as soon as it becomes available. So with this, I would like to invite my dear friend, Dr. Basit Salam, who is a radiologist, consultant radiologist at Sultan Qaboos University in Oman, Muscat. And Basit is going to talk about imaging in bladder cancer in various parts of its management. So Basit, the screen is yours. You can share.
Thank you,
Yes,
Dr. Hamad. And
yes.
good to be part of urology, as always. So I will start with my presentation. I hope you guys can see my screen.
Yes, Basit, we can see your screen.
So urothelial cancer, also referred to as a transitional cell carcinoma, is the most common primary malignancy of the urinary tract. And it can be found along the entire length of the urinary tract, starting from the renal pelvis to the urinary bladder. As imaging and treatment vary according to where the urinary tract tumor arises, each location is separately addressed radiologically, but the imaging findings are essentially the same for all of these type of tumors. Their distribution, and the relative frequency of urothelial cancers along the urinary tract is that bladder is the most common region that is being involved by these tumors, and the percentage is around 97%, followed by the renal pelvis, which comprises of 2 to 3%, and ureter are considered to be the least commonly involved region by this tumor, comprising around 1%. I'll be showing you different cases on the imaging and how they appear on the imaging. So the radiological features depend on the morphology. The papillary tumors, they usually appear as soft tissue density filling defect, whereas the infiltrating type or the non-papillary types are harder to detect as they are often sessile. And that makes them quite challenging on imaging as well to be detected. CT is primarily the imaging modality that is being used for the diagnosis as well as the staging. As plain films has very limited or you can say that almost non-diagnostic role for the assessment of urothelial tumors. Ultrasound, you may see sometimes hypoechoic mass within the renal pelvis or the dilatation of the calyx, which may result in hydronephrosis or focal callicial dilatation. Therefore, since ultrasound is highly operator dependent, so mostly the CT plays the major role in the detection and staging of these kind of tumors. On CT, they usually appear as a soft tissue density lesion, which only shows some mild enhancement, and that is usually the differentiating feature for these tumors from renal cell carcinoma, which enhances intensely on imaging mostly. And they are usually centered around the renal pelvis region. The epicenter of these tumors are towards the renal pelvis, that is towards the collecting system. And unlike the RCC, they do not distort the renal outlines, even if they are large and infiltrating. The normal renal shape is usually maintained. In larger tumor, we expect like RCC to see areas of necrosis. There may be small calcification presence located on the surface of the papillary projections. Whenever we do CT for these kind of tumors, the CT protocols also includes different phases like the arterial, venous plane, as well as the urography. But for urothelial tumors, we prefer doing the plane, the venous phase, and the CT urography, which is considered to be mainstay for both the diagnosis and staging, and it has the sensitivity of around 97%, and the specificity is reaching till 99%. On all the modalities which outline the collecting system, we will see, including CT urography, persistent filling defect, which may cause distortion or obliteration and sometimes amputation of the calyx where the lesion is located. The obstruction may lead to hydronephrosis, or if the lesion is infiltrating into the entire renal pelvis and the callices, there may be non-functioning kidney without any hydronephrosis. The calyx may be distended by the tumor, which is present within it, and sometimes it is referred to as oncocalyx, or it is not opacified by the contrast. And in that case, it is called an amputated calyx. This is the example of a CT urogram. You can see that the kidneys are excreting contrast. And if we see the left kidney, this is a coronal CT scan, you can see that there is an infiltrating type of lesion which is getting into the collecting system. And you can see the size of the two kidneys. This kidney is very small as compared to the right one. The paranephric fat also is showing stranding. Another example of multifocal type of urothelial cancer, you can see that there is a nodule kind of projection which is showing mild enhancement, which is less than that of the renal parenchyma in the renal pelvis on the left side, and there is another additional lesion which is seen in the proximal right ureter. You can see that this ureter is very much distended versus the contralateral ureter, and you can see it is filled by a soft tissue density lesion. And if we move inferiorly, you can see a nodular density which is seen within the urinary bladder. So this is a multifocal type of urothelial cancer. This is another CT example showing you a large soft tissue density lesion, which is showing subtle enhancement and which is infiltrating into the calyx of the entire left kidney. And this is another example of urothelial cancer arising from the renal pelvis and infiltrating into the calyx. This is a challenging case because in this case, if you see that the lesion is situated in a way that this is also infiltrating the renal parenchyma as well. But the epicenter, the differentiating point that this is most likely a urothelial cancer is that the epicenter or the major bulk of this tumor is towards the renal pelvis. And you can see that this lesion is also enhancing quite than the previous examples that I have shown. But the differentiating point, you always compare the enhancement of the tumor with that of the renal parenchyma. For urothelial tumors, it is always less than that of the renal parenchyma. And you can appreciate, since this is a larger lesion, there are areas of necrosis present within this lesion. Similarly, the ureter also has the similar findings that they present at filling defect with mild enhancement. And the distal ureter is the most common region being involved by this. And in about 2 to 5% of the patients, we may see bilateral tumors. Here again, CT helps us in diagnosing as well as staging the tumors, and they will show you persistent filling defect with or without hydroureter and hydronephrosis, depending on the location of the lesion and the size. Another example, you can see a persistent filling defect with distension of the left ureter. You can see that this is a very large lesion. Because of they usually present with hematuria, you see some filling defect in the distal part of the ureter as well. This is the axial section of the same patient. You can see a soft tissue enhancing mass lesion, which is involving the left ureter. Another example of enhancing soft tissue lesion in the proximal part of the ureter. Here you can see that some contrast is trickling from the center of the ureter, and rest is appearing as filling defect. This is on the CT urogram, and this is during the venous phase of the CT. A bladder is the most common organ to be involved by the urothelial cancer, and there is a known association of urothelial cancers, which usually develops in the bladder diverticulum, and the presumption is due to urine stasis. There is chronic urothelial irritation and potential exaggerated exposure to the carcinogenic, resulting in tumor development. So ultrasound sometimes is good in picking up the lesions, but staging always required the support of cross-sectional imaging. CT and recently MR has also gained much popularity in identifying and staging of urothelial cancers involving the urinary bladder. In ultrasound, you will see a hypoechoic lesion, which may be just seen as a thickening of the bladder wall, or when sometimes it can be seen as a projecting lesion with some stalk or papillary projections, which are appearing as irregular areas over the surface of the lesion. For staging and diagnosing, CT and CT urography is the primary modality, which is extensively used, and now for the last few years, MR has been gaining some popularity in staging and accurately diagnosing the bladder cancers. So they usually appear either as focal thickening of the bladder wall or as masses. And when they present as masses, they have the soft tissue attenuation, which may have calcification. And CT is usually very accurate in staging T3B and T4 diseases. And nodal involvement, which is seen in around 30% of the patients who have T2 tumors and in 60% of the patients who have T3 and T4 tumors. CT is very accurate in picking up involvement of the lymph nodes. And tumors that are large and have papillary morphology will appear as a filling defect, and they usually show mild enhancement that is differentiable from the surrounding structures. So this is CT venous phase on the left side of the screen, and the right one is the image from CT urogram of the same patient. You can see that there is enhancing. If you compare it with the background of the urine, you can see that this lesion is slightly irregular along its margin, and it is enhancing. And you can see that this wall of the urinary bladder is showing more enhancement versus the rest of the wall. And on CT urogram, you can see that this is appearing as a persistent filling defect. And you can see that there is a definite fat plane between the seminal vesicle and the bladder wall. This is a coronal and sagittal image of the same patient. You can see the thickening of the urinary bladder wall and this projection of this lesion inside the lumen of the urinary bladder. Another example of bladder lesion, which is extending into the left-sided vesico-ureteric junction and resulting in dilatation and involvement of the left distal ureter as well. This is the venous phase as well as the CT urogram, and you can see that this lesion is also showing areas of necrosis. Another slightly more aggressive lesion in which you can see that the big length of the urinary bladder is involved along the left lateral as well as the right lateral wall. And this is again extending into the left vesico-ureteric junction, causing dilatation of the ureter as well as the left collecting system. You can see that the entire thickness of the wall is showing abnormal enhancement, which is suspicious of extension of this lesion into the paravesical fat as well. Here, if you see, the fat also is showing significant stranding. Another aggressive lesion, which is infiltrating and involving the right vesico-ureteric junction, and you can see that this is occupying 2/3 of the urinary bladder. So MR basically has gained much popularity because of its high and superior soft tissue contrast, and it is considered now more accurate for staging of the bladder cancer. And usually the lesion is iso-intense on T1, which is similar and sometimes very challenging to be differentiated. Therefore, we mostly rely on T2 weighted sequences in which the lesions is slightly better appreciated, and it appears and it can be seen quite easily. Because the signal of the bladder wall is hypointense or of low signal, that is towards the blacker side, and the lesion usually behaves and appears as hyperintense, which is easily identified. They usually show significant enhancement after giving contrast on MR as well, like on CT, but the enhancement is better appreciated on MR versus CT. This is a T2 weighted image of the urinary bladder. You can see that this hypointense or black thin rim is the normal wall of the urinary bladder. And if you see that this irregular thing is the lesion, which is along the left lateral wall of the urinary bladder, but you can see that this is not infiltrating into the perivesical fat. We can clearly see the intact wall of the urinary bladder. These are the two images which are always read in conjunction. This is the DWI, which is commonly called the diffusion weighted sequence, and this is the ADC mapping. These lesions usually appear bright or show hyperintense signal on DWI, and on subsequent ADC mapping, they should be appearing low or hypointense to confirm that this is a definite suspicious tumor. This is an example of a patient who also have irregular bladder lesion. You can see that the bladder wall is thickened here, but still you can see that there is no paravesical infiltration, and we can clearly see the hypointense rim of the bladder wall, which is still maintained. PET has a very limited role because all the isotope is excreted through the kidneys and collected as a urine into the urinary bladder, making the sensitivity of PET to be very low because of this technical issue. But it is good in for the assessment of distinct metastasis in challenging cases. I will be talking about the new, not very new, but relatively new development of multi-parametric MR for the staging of bladder cancer. Unlike for prostate cancer, which is primarily used for diagnosing, the MPMR is basically more for local staging of the bladder tumor, and that is the T staging. And it includes T2 weighted sequences, which provides high spatial resolution and reduces the staging errors. And this is also called as a structural sequence. The DWI and dynamic contrast enhanced sequences are considered the functional sequences, which improves cancer detection and helps differentiate superficial lesions from those infiltrating the muscularis mucosa. Sorry, not the mucosa, the propria, because mucosa is not possible to be seen on MR. And MR usually the anatomical thing in MR that we can see is basically only the three layers, which is the urothelium and lamina propria. They usually are seen towards the inner side, not separately. And the detrusor muscle usually appears as a hypointense rim, which I showed you in the previous sections, and I will subsequently show, and only the paravesical fat. These are the three things that you can differentiate on MR quite easily. So T2 weighted images basically shows that the signal of detrusor muscle is hypointense or low signal intensity. And the lesion usually behaves differently on imaging, and usually they are towards a brighter appearance, or what we technically call them as a high signal or hyperintense on MRI. And bladder cancer sometimes can also demonstrate intermediate signals, and there may be, but definitely we can see that disruption of the hypointensity of the normal detrusor muscle, which raises the suspicion of possible involvement of the muscle. And after reviewing the T2, we have to complement the diffusion weighted sequences along with the ADC mapping, and this abnormality should be persistent and should usually appear as hyperintense. And on ADC mapping, this will show low signal, suggesting that there is involvement of the detrusor muscle or not. And after reviewing these two sequences, we have to complement the contrast enhancement pattern. And whenever there is involvement of the muscular layer, the enhancement will be definitely seen. And we can also see when there is extension into the paravesical fat very clearly on T2 as well as DWI and on dynamic contrast sequences. This study has, which was done in 2017 and was published in European Radiology, concluded that MPMR is a reliable staging tool for bladder cancer, and they have said that it should be done routinely done before any resection because it helps in recognizing muscle invasive bladder cancer quite accurately. Another study that was published in 2020 in British Journal of Radiology, they also emphasize the role of MPMR in the T staging of bladder cancer. And there is one more interesting development, which is YREDS, and it was started by the urologist in Europe, by the European Urology Association. This study also has described two meta-analysis for evaluation of bladder cancer using MR, which pooled the sensitivity and specificity between 90 to 92% and 78 to 88%. And this study also concluded that that these two meta-analyses have emphasized that the imaging preferably should be done on a MR machine that has the strength of 3 Tesla, because it has better detection and soft tissue contrast makes the staging more accurate versus 1.5. And the timing of MR is important, and like in prostate, we prefer doing before any intervention. Similarly, we prefer doing MPMR before any TURBT or any chemotherapy. And in cases in which the treatment has been started, there should be at least an interval of 8 weeks for those inflammation and swelling changes to get settled for the accurate staging. These are images from T2 diffusion weighted sequences, ADC, and contrast enhancement. You can see there is a subtle hyperintense lesion, which is slightly hyperintense to the muscle, but you can see that this is confined to the inner layer of the urinary bladder. The normal hypointense signal of the muscle is maintained, and the fat on the paravesical region appears clear. And this is showing bright appearance on diffusion and showing low signal intensity on ADC mapping, and subsequently there is enhancement. So these findings, which they should persist, and all of these findings should complement each other to accurately characterize the lesion and stage as well as the lesion. Here again, this lesion is on the near the dome. You can see that this is slightly infiltrating into this hypointense rim. Like you can see that this is very clearly seen, but here this is not as clear as this normal bladder wall. So there is involvement of the muscle layer, but the paravesical fat appears clear. And again, this is showing diffusion restriction on DWI and ADC sequence, and the enhancement pattern, which is extending into the muscular layer as well. This is an example of more aggressive lesion. You can see that this is the sagittal sequence, and these are showing hypointense lesion, which is extending beyond the this hypointense muscle. You can see this muscle signal is lost here. It is significantly thickened, and you can see the irregularity in the paravesical fat here also. So and this is being complemented by these diffusion-weighted sequences, which is again showing that this lesion is extending beyond the bladder margin and is infiltrating the paravesical fat. Now, like pyrids, we have YREDs, which basically is a more structured reporting scheme for multiparametric MR for bladder cancer. And it basically let us approach these lesions in a systematic manner. And this was proposed by the European Association of Urology in 2018. And it includes a combination of T2 weighted sequences, which are called the structural category sequences, the DWI, the diffusion category, and the dynamic helps us in telling the functional evaluation of these tumors. And so basically, the YREDs also have 5 categories, starting from category 1, which in which the muscle invasion is highly unlikely, and in category 4, there is a very high probability of involvement or invasion of the muscle. And the category 5 is a category in which the tumor has extended beyond the margins of the muscle into the perivesical fat or the surrounding structures. And all these sequences are given a score of 1, depending how they are. The T2 as well as DWI and dynamic contrast enhanced, they are being scored, and depending what is the appearance on T2. For example, for T2 lesions, that probably is going to be easier to explain here. V1 lesions, the tumor is less than 1 centimeter, and hypointense rim is intact, which is clearly suggesting that there is no involvement of the muscle. And usually they present like exophytic tumor with a stalk, and sometimes some high signal thickened inner layer. Sometimes these sessile lesions, they have a broad base, and this stalk is missing in those, but on none of these sequences we will see the loss of normal detrusal muscle signal. Similarly, the only difference between category V1 and V2 is the size of the tumor. For V1, it is less than 1 centimeter. For V2, it is greater than 1 centimeter. In V2 also, the muscle is intact and there is no involvement of the muscle or extension beyond the bladder. For equivocal cases, when we are not sure whether there is muscle involvement or not, this is called as category 3, in which there is some disruption of the muscularis layer, which is not very clear, and we cannot clearly see that the hypointense signals is maintained like the rest of the bladder wall. For category 4, there is definite involvement of the muscle or infiltration of the muscle by the tumor, which is seen on T2, on dynamic contrast enhanced, as well as on diffusion weighted sequences. And for category 5, there is extension into the paravesical fat into the surrounding structures. So I think with this, I would end my talk, and I'll be happy to take any questions.
Thank you, Basit, for comprehensively covering the subject. There are a couple of points, we are a little short on time, but about the use of, when you are looking at a patient with poor functioning kidney, what would be the secondary signs to exclude if there is any urothelial cancer of the upper tract?
So basically, there is going to be distension of the collecting system. That is something which is seen, but it is really very challenging to differentiate that from a tumor or from just a blood clot. And for those reasons, we can complement those cases with using limited sequences of the MR, for example, diffusion-weighted sequences, which does not need any contrast, or helps us in characterizing, because presence of diffusion restriction makes the probability of this being a cancer highly likely versus that just a blood clot. And there can be atrophy, there can be infiltration, distortion of the collecting system. But for urothelial tumors, the renal outlines are usually not distorted.
Right. Thank you very much. I think we have just...
Yes, if there is, I think, one question, what about the antigrade? So
yeah.
Antigrade we can do an antigrade study, but that also has the limitation that it will only tell us that there is a persisting filling defect, which can be blood clot or a lesion, but accurately characterizing this on antigrade study is also a bit challenging.
Okay, thank you very much, Basit, Mustafa, and Professor Hussain has left already. So I think we have very extensively covered the subject. Next week, we will be dealing with radical cystectomy, both open and robot-assisted, and going to talk about complications and how to avoid those complications during radical cystectomy. Thank you for being here, and I hope you have learned from these three presentations. Have a very good evening, and Khuda Hafiz.
Thank you.